initial staging, interval comparison, post-treatment surveillance. So our presenter for the day is Dr. Linda Mose. Dr. Mose, if you may start sharing your screen as I do a brief introduction. So Dr. Linda Mose is a consultant radiologist based in Kenyatta National Hospital. She's very well experienced in breast imaging and management in the line of management of initial diagnosis, staging, interval imaging, and even post-treatment surveillance. And she's very passionate about breast and women health and imaging. She's very instrumental in our institution as KNH. And so we are glad today to have her share with us the role of radiology in breast cancer management. Dr. Mose, if you're ready, please go ahead. Welcome. And I would also ask that we post our questions or comments on the Q&A section of the tabs on the Zoom platform. And at the end of the presentation, we will be able to answer your questions to the best of our knowledge. Welcome, Dr. Linda.
Thank you for the kind introduction, Dr. Mamai. So our topic of discussion today is imaging in breast cancer and radiological staging of breast cancer. Just a brief background. We had a very good lecture last week. There was a series of presentations which again touched on the diagnosis of breast cancer and management, where a lot of information was again tackled. So my focus today will be on the imaging modalities that we have that aid us in the screening and diagnosis of breast cancer and the staging. Mammography was tackled to a large extent last week, so we'll do just a brief mention today. So breast cancer, why are we focused on this topic? Why is it an area of interest? We know that cancer is on the rise globally, and even within our population, we see cancers, and more so, we are seeing a lot of cancer in younger patients, as opposed to the demographics that used to be there previously, where we see them in elderly patients. We're having people coming with cancers in various regions, affecting various systems. And we are seeing them at the prime of their lives, patients in their 30s, in their 40s, even as early as 20s. Breast cancer being no exception, and we are having very young patients with this. And even globally, it is said to be the cancer with the highest incidence among women, with about 2.2 million cases reported according to the Global Can 2020 statistics. It was also reported to be a leading cause of death, with greater than 500,000 deaths in women each year. In our population, it is the leading cancer in terms of incidence, according to the statistics of Global Can 2020, with an incidence of 16.1%. This again is an increase from the previous Global Can 2018 statistics, which had put it at about 12%. And currently, it's also the second leading cause of cancer-related deaths in the country. So it is a topic of importance because some of these deaths actually may be preventable with timely intervention. So in Kenya, we are also seeing cancer burden, the breast cancer burden in younger populations. We get people who are, majority of the people who are affected are between 35 and 45 years. These are people who are the prime of their age, so very productive people, but the cancer burden has now fallen on this age group. The other thing to note is in our population, most of our patients come to hospital late, so the diagnosis is made late, or sometimes they may seek healthcare in facilities which are not equipped to manage breast cancer, from diagnosis and even linkage to care. And this again, of course, affects the survival rate of these patients, because sometimes when they eventually come to us there, we see them when they already have advanced disease. Early detection and treatment has been shown to improve the 5-year survival rate. And for patients who are detected where cancer is detected early, you have more than 80% survival rate, the 5-year survival rate for early localized breast cancer. So early detection is key, and the detection strategies we employ are early diagnosis and screening. So this is a representation of what we had just discussed, the breast cancer burden, and we are seeing that in the statistics, the blue bar represents the incidence. We can see that it's the cancer with the highest incidence in our country, then followed by prostate cancer in men. And the red bar represents the mortality. So again, we see it is the second leading cause of mortality. Screening, in terms of screening, it involves testing of asymptomatic women. So in this, in screening, we want to identify disease in unrecognized disease in an apparently healthy asymptomatic population. Most cancers which are detected at the level of screening tend to be early. Therefore, even the prognosis for the patient usually is good. When we're doing diagnostic imaging or diagnostic testing, we are testing symptomatic clients who have come with symptoms of breast disease or have come due to an abnormal screening test. So for screening, usually it starts with the patient. It's important for this education to be given to a patient so that the patient's clients are made aware of their breast self-awareness, so that when there's any changes, masses or lumps or something that is different than the appearance, the patient is able to tell that there is a problem. So it starts with the patient, and it's we call it breast self-examination. However, this is also at times it has been said to be controversial, because even in terms of technique, if it's not done right, a lot of these lumps may not be felt. Clinical breast examination is the other part of screening, which in this case, you have a clinician, depending on the level of the facility. And this is a person who then does the clinical breast examination and will be able to tell whether there is an abnormality, and also give more characteristics about whether, if there is a mass, what kind of mass is it, give an approximate dimension, and the other associated features, look at generally the patient, asymmetry, skin changes. And with a clinical breast examination, again, a lot of information can be obtained. Then imaging is the next modality used for screening, where the gold standard is the screening mammography. So in mammography, when we do screening mammography, we are basically looking at women who have come, or men who, new women who have come with no symptoms. And we want to see whether there is any identifiable abnormality. So recommended screening usually is from around the age of 40 in a patient who otherwise has no additional risk factors. So the focus of screening is actually to detect the disease early, and then also ensure timely management of any detected cancer. Recommended age is 40 years for women who are at average risk of breast cancer. And for women who are at increased risk, these are clients who may have mutations like the BRCA mutations, very strong family history, first-degree relatives, people who generally are said to be at higher risk. Maybe they had mantle radiation earlier. These women usually will need screening at earlier ages, and they will require more intensive screening. So mammography screening should start earlier in these higher risk groups, and supplemental screening modalities such as contrast enhanced MRI can also be used, and especially in younger clients because of the dense breasts. Ultrasound can also be considered for those who qualify but cannot undergo MRI, though it is not really a screening modality. Ultrasound is supposed to be a complementary modality. But in cases where maybe MRI is unavailable and the patient is not amenable to mammography, then we can consider ultrasound for this category of patients. For diagnosis, again, this was tackled last week. What is important is to emphasize on the triple assessment, where the clinical breast examination is undertaken by the surgeon or the clinician. And with this, again, information can be obtained if there are masses, evaluation of the axilla can be done, presence of discharge. And then this is followed up by imaging. And in imaging, we look at mammography as the gold standard in screening. And then the other part of the triple assessment is histological diagnosis, where for any abnormalities that are found on imaging or on physical examination, then this patient has to have these abnormalities sampled. So imaging modalities, we mainly use mammography, the standard, which is the 2D mammography, or the 3-dimensional mammography, which is the tomosynthesis, digital breast tomosynthesis. The other modality is ultrasound, as we have alluded to, and MRI. These are the modalities usually we use for diagnosis of breast cancer. There are other modalities, of course, which now come in when we are doing staging or we want to localize lesions and we want to biopsy. So then we may have things like PET-CT, which then comes in staging, but not as a diagnostic modality. For biopsy, we can have image-guided biopsy, either using mammography, which is stereotactic, using breast ultrasound, or MRI guided biopsy, where the facilities are available and the lesion is only seen on MRI. So mammography, as we cannot emphasize more, it's the gold standard in screening, and it is the only screening tool that has been shown to reduce breast cancer mortality. It is crucial in detection of breast cancers, and it often shows changes in the breast before a patient or a physician is able to feel these changes, sometimes even up to 2 years before these changes become palpable. So early detection of breast cancer is crucial because then it gives you the potential to cure the patient and also makes the breast conservation therapies amenable. Mammography is also important as a baseline examination in patients who have been found to have an abnormality, whether through palpation, and sometimes we've seen patients who've done biopsies, then they come back for imaging, or done surgery and come back for imaging. But to have a baseline study so that even for follow-up of these patients, it is important to have this mammogram done prior to any intervention. So again, we go back to that role of triple assessment. You have that clinical breast exam, you have the imaging, you have the pathology, and then the patient is managed. Mammography, as I've also talked about, in patients who have had a breast cancer diagnosis, it is important to have that baseline mammogram so that in future, when we are doing comparative studies, we are able to know if there's been any response, especially where the, maybe breast conserving surgery has been done, or if you've had a patient with unilateral mastectomy. The other thing is sometimes you may have, in rare cases, patients who have bilateral breast cancer. So in such cases, you may find a breast with a lump that is palpable, and the other breast has abnormalities, maybe microcalcifications that may not be palpable clinically. So we might treat one breast, follow up the patient a year later and find an abnormality. But with no baseline, then it is hard to tell whether this is a recurrence or whether we had bilateral breast disease, which is why we emphasize that we should always have a baseline mammogram or baseline breast imaging for any patient prior to any treatment. The standard views, we do craniocaudal and mediolateral oblique views for mammography. And we can have additional views done for specific indications or findings. For example, if we have masses that are localized more towards the axilla, we can have axillary tail views. If we have masses around the parasternal area, along the midline, we have cleavage views. So we have different views which we can employ as additional or complementary views depending on the indication. So traditionally we used to use a screen field mammography or unconventional mammography, but with the radiology, we know that it's a field where, with a lot of technological advancements, we are having newer and newer modalities, which of course come with advantages. So currently, a lot of the mammography done globally is digital mammography, which leads to better cancer detection because of improved contrast resolution. And there's also capability of post-processing. So things like spot compression, which we would do before so that you see microcalcifications, may not be required in such cases because you can actually magnify the images once they've been sent and you're able to pick out these features. And further improvement on the digital mammography is the digital breast tomosynthesis, in which we have the tomographic images of the breast, where we have thin slices of the breast acquired over a predetermined range. And so this enables you to look at thinner sections of the breasts. It also improves the specificity in terms of detecting lesions. One of the drawbacks in mammography is in increased breast density, you can have a problem of summation where you have overlapping of fibroglandular tissues and other tissues within the breast. And with that overlap, you may have a pseudo mass created. So tomosynthesis is able to eliminate this because then you're looking at thinner sections of the breast and it removes that effect of summation. The other thing is the improving of sensitivity, the increase in sensitivity. So when you have masses, you're able to define the masses better. On tomosynthesis, you're able to define the margins better. So if a mass has angulated margins, because you have removed the overlap, you're able to actually define those masses better. So it is the one modality that has shown both increase in sensitivity and specificity in breast cancer detection. We will move to MRI. It's a modality that is also very useful in breast imaging, especially in younger patients who have increased breast density. One of the limitations of mammography is the dense breasts, as I've talked of that effect of summation of tissues due to overlaps, or the effect of masking pathology, again due to overlap. So as much as DBT has attempted to address this to a large extent, you have breast densities which are extremely dense, such as the SERD category, where you may still have challenges even with the digital breast tomosynthesis. In such patients, MRI would be the screening modality of choice. And again, as we know, with younger patients, you tend to have more fibroglandular tissue as opposed to having more fatty replacement. So with the glandular tissue, again, the breasts tend to appear denser. Again, you may have the same limitations. So that is why we again recommend MRI if we have patients who require screening in younger populations. Then MRI is the go-to modality. It's also useful in when we have multifocal, multicentric masses, where you may want to see the characteristics of these masses and how they behave after contrast administration. You may also have mammographically occult tumors, and especially patients with dense breast parenchyma. And this can help to also detect additional occult cancer foci. It is important also when you're looking at patients who you're planning to do breast conserving surgery, because when you do the enhancement, you're able to see the enhancement pattern of the breast parenchyma, and you can actually tell which areas of the breast are showing abnormalities. So it's an important modality when in planning for breast-conserving surgery. Also useful in estimation of tumor size, where with detection of invasive component of ductal carcinoma in situ lesions, and in the presence of malignant axillary nodes with no primary tumor seen in the breast, on mammography, it can act as a problem-solving modality. MRI is also useful in assessing for recurrence, disease recurrence, especially in patients who have had surgery. And we look again at the enhancement of the parenchyma. After 18 months, it is said that we should not really have enhancement. So if you start to have a patient who has enhancement at a scar site 2 years after the operation, then this is a patient who may need to biopsy again to see if there is a recurrence. So again, for screening high-risk populations of patients, you have patients with the gene mutations we talked about, and if they are younger than the 40 years that is recommended, or younger than 35, you may then consider MRI for screening in these populations, in addition to mammography. So when we are looking at our MRI images, we use the same kind of pattern in assessing for any pathology. So you want to look at the breasts, are they symmetrical? You look at the parenchymal composition, you look at any masses and characterize the masses. Any areas where there's parenchymal distortion, any skin changes, nipple retraction, where you have ductal ectasia, you can assess the axilla and also the chest wall. We also look at the kinetic curves. So when you're looking at lesions on MRI, in terms of when we have the gadolinium enhanced type, we divide our lesions into 3 main categories, where we have an enhancing focus, which is an area of enhancement which cannot really be specified. You may have enhancing masses, which again are described, or non-mass-like enhancement. So where you don't have a mass per se, you cannot localize this mass in terms of space. I give it a 3-dimensional feature in terms of space. Then you look at the non-mass-like enhancement and see whether the features support benign pathology as opposed to a benign etiology as opposed to a malignant etiology. So when you're looking at focus, these areas of enhancement, typically they appear almost dot-like, less than 5 millimeters in diameter, and they are too small to characterize. Most of the time, these are typically just benign. When you're looking at masses, it is something that occupies space, just like the masses we see elsewhere in the body. It is a 3-dimensional structure that is seen to occupy space within the breast. So when you see the mass, you should be able to define its shape. You should be able to define its margin. Is it circumscribed? Is it lobulated? Is it spiculated? And also looking at other features, internal characteristics. So we look at the signal on MRI. And when you're looking at the signal, for MRI breast, the one thing that we say is a constant is when you see bright lesions on T2, these lesions tend to be benign. T1, again, bright, we tend to think of lesions in fat, but we use a T2 signal. When you see low T2 signal, in most cases, you're thinking we have something maybe a bit more concerning for malignancy. And there's one exception to this, one type of cancer where the T2 signal is also seen to be high, and that is a colloid carcinoma. So other than looking at the internal characteristics, we also want to see the enhancement pattern of this mass. And also we do assessment of the kinetic curves, where when you're looking at the kinetic curves, you want to see if this is a mass that rapidly takes contrast and rapidly washes out, which then puts it at a higher category of being of the probability of being malignant. I look at one where if you have progressive enhancement, then you're talking of likely a benign mass, or one which enhances and then has a plateau, then you're looking at a mass that is in between. However, these kinetic curves are not cast in stone. Sometimes you may have a mass which has a plateau and it's malignant. You may have that mass which shows progressive enhancement. Although the probability is low, again, there's a risk of also the mass being malignant. So a lot of masses which either show the type 2, that's a plateau, or the rapid washout curve type 3 tend to be biopsied. So non-mass enhancement, we're looking at enhancement without a detectable three-dimensional mass. So you may have focal, you may have ductal, you may have linear, segmental, regional enhancement. You may have diffuse enhancement. Most of the time, diffuse is not too worrisome. So this is an example of an image with focal enhancement. We see the area that appears bright on the image. So that is an area which is suspicious, and it's an area we possibly would want to biopsy. Again, we can have the linear type of non-mass enhancement. In this case, we're seeing an image where we have a mass which is showing enhancement, and we also have this linear extension anteriorly and posteriorly, which again, on biopsy, in this case was invasive ductal carcinoma. The enhancing foci were foci of DCIS, the linear enhancing foci. We can have clumped enhancement. So again, you see the bright areas on the screen in this image clumped together. So again, this is again a mass that would be suspicious. You may have multifocal disease in this case. The other features we also want to look at when we are looking at our MRI is the skin thickening. We want to see whether there's nipple retraction. We also want to see whether any masses we've seen are extending to involve the chest wall. We want to see whether the pectoralis muscle is infiltrated or there is no architectural change, and adenopathy. We're able to tell whether the nodes are suspicious. Either we look at the enhancement and we look at other features such as restriction or diffusion. So limitations, MRI is not widely available or accessible. It's an expensive modality also. And there's also the claustrophobia aspect. Patients who are claustrophobic may not be able to stay still in an MRI machine. And remember, this is a modality that is very sensitive to any motion. So there are some limitations. Patients who are very sick may also not be able to withstand the long scanning times. Ideally, when we are doing this exam, we try to time it in the second week of the cycle so that we avoid increased background parenchymal enhancement, which can lead to abnormal interpretations. Breast ultrasound. This is a useful modality, especially in younger women. And it's also useful in patients with increased breast density. It is used as a complementary modality in most cases when you have non-conclusive findings on mammography. Also useful in pregnancy because of the lack of ionizing radiation, and also in lactating females, and then we know the changes in pregnancy and lactation, again, the breast usually become denser. So again, it is the modality to use in such patients. For evaluation of the axilla, you're looking at this axillary nodes, looking at the size of the nodes, shape of the nodes, and the vascularity of the nodes, cortical thickness. It's able to tell us whether this node is suspicious and needs to have biopsy. Also, when you're looking at masses, you're able to characterize whether they are cystic or solid on ultrasound. So I have several images here, just showing the different, some different findings you may have on ultrasound. In the first case, we have first image, we have a well-circumscribed lesion. We're seeing good margins and posterior enhancement. No echoes internally, so it is an anechoic mass. So this is a simple cyst. Usually these ones don't require much intervention. They're the ones we typically give Byrat's to. And the next image is a fibroadenoma. Again, we're looking at this image, we're seeing a well-circumscribed mass with smooth margins. We're not seeing anything concerning. The orientation again is parallel, meaning it is parallel to the skin, meaning it's wider than it's tall. So wider than tall. This again is pointing towards a benign mass of fibroadenoma. So there are some features, of course. You may have masses that can look like fibroadenomas, but you have a few changes which once you recognize, you need to upgrade and probably give them a Byrat's form and have them biopsied. You may have such slight angulation of the margins or microlobulations, or you have a mass which is not oriented parallel to the skin, so it's almost taller than wide. So these ones do not fall in that category of typical fibroadenomas and they require biopsy. So when you're moving towards masses, again, when looking at shapes, angular margins, these are masses you want to biopsy. So in this diagram, it's a pictorial representation of the features that tell you about the probability of the mass being malignant or benign. So this is an example of an ultrasound image in a patient with non-breast cancer, and we can see the irregular mass with indistinct borders. And when you're looking at the mass, we're looking at the surrounding parenchyma. It has an echogenic or hyperechoic halo. This is a feature usually that would indicate that this mass is likely to be malignant. And whatever we are seeing appearing as the echogenic halo around it is all part of the abnormal mass. So there may be some areas of infiltration within that echogenic halo. So as much as we see the mass looks hypoechoic, the surrounding parenchyma there has some distortion and parenchymal changes, so likely also infiltrated by the mass. We have a mass here, which is seen and almost looks like a fibroadenoma. However, we see some of its margins appear sharp and angulated. And this mass is a mimicker of also fibroadenoma. In this case, it is cancer. The other thing is fibroadenomas, we know the demographics, we tend to have them in patients who are younger. Basically, patients between the age of 15 to 25, that's where you find majority of those masses. If you have a woman who's above 40, above that age group, and they're coming with a palpable mass for the first time and its features look like that of a fibroadenoma, this is a mass we should still biopsy because it is not typical for you to have that as a presentation at that age. We are looking at also ultrasound, the ability to differentiate between the composition, cystic versus solid. So in this case, we have a complex cyst. So we have a mass that is part cystic, part solid. We see the solid component, which also takes up some color on color Doppler evaluation. And in such a case, usually you target to biopsy the solid component. This was also a case of intracystic cancer. So when you have these complex cysts, always we say that you biopsy the solid component. This is a case of a breast abscess where you again see this lesion that appears very aggressive, which can mimic cancer. With breast abscess, again, we tend to look at the pattern. You'll find that this is a lesion that has been there for a fairly short duration, almost exclusively in lactating patients, especially those with mastitis, although it can occur outside lactation. And important to notice that it may mimic a mass. So usually when you do a bit of compression, you may see some mobile fluid within this lesion. So this is also important to have at the back of our mind. So when we are doing reporting, it's important to have the patient biodata. Generally, There are information such as lactation history, LMP, age of menarche, menopausal status, because again, those will guide you towards the possible pathologies you may be dealing with. So this was again tackled last week, BIRADS assessment categories. For patients with BIRADS 0, usually this is an incomplete evaluation, so you need to have further imaging of comparison done. BIRADS 1, usually this is either on ultrasound, mammography, or MRI. It shows that there is no evidence of malignancy. BIRADS 2 lesions are the ones that we say are benign, the fibroadenomas and simple cysts. Probably benign findings usually will require a short interval follow-up. Patients probably who you're suspecting may have some mastitis, abscesses. They may get treatment after treatment, they come for follow-up scan after maybe 2 to 4 weeks, and you do that assessment with an ultrasound. If you're thinking of mammography, then you're also 50-50, where you're thinking of probably benign findings. These are patients you want to image in an interval between 3 to 6 months. Suspicious abnormalities would constitute BIRADS 4, where you have 4A, B, and C, and any BIRADS 4 usually we recommend biopsy. In BIRADS 5, so radiologically, these are patients who you're saying has a malignancy. So we are actually just waiting for the histological diagnosis. So when you have features that are highly suggestive of malignancy, when you're looking at the mass and you're seeing features that are very suggestive, then we assign that a BIRADS 5, and 6 is histologically proven. So PET-CT also another modality useful when you have a patient who's had breast cancer diagnosis, it can show the detail to greater detail because you're looking at the areas of increased, the FDG-avid areas of increased metabolism within these masses. Also important in looking at nodes and assessing for distant metastatic disease. So I'll move to breast cancer staging. The extent, why do we stage breast cancer? The extent or stage of disease and diagnosis is key information because this will again guide the treatment that this patient will receive. So we need to have the staging done accurately. This helps in determining whether the patient will have chemo, whether the patient will go for surgery, whether you have neoadjuvant chemo, or whether it is important because then it tells you where to go next. So we have several cancer staging systems that are used worldwide, and they are chosen depending on the needs and objectives of the clinical setting. Most clinical useful staging system is the TNM, and this is the one that is widely used. So we'll discuss it briefly. For the TNM staging, we look at the T stage, where we look at the local extent of the disease with use of numerical subsets, which indicates progressive extent of the malignant progress. So we're looking at T0 to T4. N would stand for nodal status, which will indicate presence or absence of lymph node metastasis. So again, we have the range from N0 to N3. Metastasis, which is the M, where we're looking at presence or absence of metastasis outside the primary site of pathology. So we're looking at distant metastasis. So we have M0 or M1. So in TNM classification, TX, this means a primary tumor cannot be assessed for some reason or the other. When we have T0, there is no evidence of primary tumor. TIS, ductal carcinoma in situ, or when you have Paget disease of the nipple, not associated with invasive carcinoma or DCIS. T1, usually again a mass that is less than 2 centimeters in greatest dimension. T2, between 2 to 5 centimeters. T3, greater than 5. T4, where you have a mass of any size with direct extension to the chest wall and or skin. So in T4A, you have a chest wall extension without invasion of the pectoralis alone. with no invasion of the pectoralis alone. T4B, you also have the skin involvement. T4C, you have both A and B, and T4D, when you have inflammatory breast carcinoma, we usually give it a T4D. So these are a representation of, it's a mammogram image showing a ductal carcinoma in situ. This is the most common non-invasive breast cancer, and the cancer is usually limited within the ducts, and it may be multifocal. On imaging, it is in many cases you may underestimate the burden of the disease in such patients, and a lot of time you'll find that the disease has involved more than what you've seen. 80% of cases diagnosed on mammography alone, and this is done on basis of looking for the microcalcifications. So we look at the microcalcifications and their morphology. If they are of suspicious morphology, then we biopsy the microcalcifications. Localized breast cancer. This is T1 and T2 tumors. Localized or early stage breast cancer includes tumors which are less than 5 centimeters and with no nodes or involvement of less than 4 axillary nodes. So usually for evaluation of the axilla, we look at we first examine it with an ultrasound. If we see pathological lymph nodes, the next step is to do an FNA. If they are positive, usually then a PET-CT is performed to exclude more advanced disease. Where no suspicious nodes are found on ultrasound, the next step is to do a sentinel node procedure. So the sentinel node will be the first node that the malignancy would go to in case of metastasis. So when you're doing the sentinel node procedure and we inject the radio tracer, that node that is the first to take up contrast is the one that usually is biopsied and assessed for any malignant cells. In the event that no malignancy is found within that node, then the patient is said to have no nodal disease. And in cases where now we find any malignant cells within that sentinel node, then usually you have to during treatment, then you have to also consider the other nodes, either do an axillary clearance, or depending on whatever therapy is given, the other nodes then have to also be considered. Locally advanced breast cancer, this is includes T3 tumors which are greater than 5 centimeters, or T4 tumors with invasion of the skin or chest wall. Here we have a nodal disease where you have more than 3 axillary lymph nodes, or ipsilateral supraclavicular nodes, infraclavicular, or internal mammary nodal involvement. So tumors spread in breast cancer can either be via lymphatics through the regional nodes, and also you can have circulatory via the circulatory system, and that's how you get metastasis to distant sites. So in nodal evaluation, usually we evaluate axillary, infraclavicular, internal mammary nodes, which are now, we assess the size of the nodes, we look at the cortex, and also look at the density of the nodes. If you're using CT, we look at the margins, we look at the shape, and we also look at perinodal invasion. And for every suspicious lymph node, biopsy or an FNA is performed. This is an example of a normal axillary ultrasound image. So a normal axillary lymph nodes, where we have lymph nodes, the one point we see that is depicted by the white arrow is a benign node. You have an echogenic hilum with a thin cortex. It appears almost reniform. So the hypoechoic cortex usually represents the lymphogenic tissue. The echogenic center, the one that is brighter at the center, represents the fat within the hilum, and we also have vessels within the hilum. So when you have nodal metastases, you will have changes in the appearance of these nodes. They appear round, they may appear irregular, they may appear spiculated. Usually they will lose that echogenicity that is central, so that bright signal on ultrasound will be lost, and you'll see a node that appears dark, hypoechoic, with loss of that echogenic hilum. You may have some echogenic hilum, but with a thickened cortex. And what we use for our cutoff is 3 millimeters. Anything that is bigger than 3 millimeters, or even if it's just a focal bulge of that cortex that is increased, this is a node we still have to sample. We need to do an FNA. So this is this ultrasound image is a demonstration of nodes that are metastatic, that have metastatic disease. So for lymph node evaluation, NX, regional nodes cannot be assessed. For example, if a patient has had surgery and these nodes were previously removed, they had axillary node dissection, it's NX. N0, there's no evidence of nodal metastasis, either by imaging or clinical examination when the clinician does that clinical breast exam and you don't palpate any nodes. CN1, you have metastasis to level 1 or level 2 axillary lymph nodes, which are mobile. So these are nodes that are seen lateral and inferior to, or just posterior to the pectoralis major muscle. If you have metastasis to this, we consider that N1. Micrometastasis, again, is a subcategory of N1. CN2, you have metastasis to fixed ipsilateral level 1 and 2 axillary nodes, or metastasis to internal mammary lymph nodes alone on the same side. So again, this is subcategorized into 2A and 2B, where 2A, we have level 1 and 2 axillary nodes. In 2B, we have internal mammary nodes. In N3, CN3, we have metastasis to ipsilateral infraclavicular level, that is the level 3 nodes, or to ipsilateral internal mammary nodes and level 1 and 2 axillary lymph nodes, or metastasis to ipsilateral supraclavicular nodes. So again, we have the subcategories. So when you're looking at distance metastasis, we are looking at where M0, where there is no evidence of metastasis to any region outside the primary tumor, any other organ outside the primary tumor, such as the lungs, liver, bones, or any other structures. So when we have no clinical or radiographic evidence of distant metastasis, then we assign this category. M1 would be distant metastasis present either by clinical or radiographic detection. And MX category is no longer used. This was removed in the revised classification, the latest. So if the presence of metastasis is not known, the cancer is still assigned M0. This is a summary of the staging, stage grouping system that we have done, the TNM. It's a chart that summarizes and also talks about the different stages from stage 0 to stage 4. So it is a good reference when you're looking at the radiologist report. We also have the P classification, the pathological for regional node metastasis, which usually, that one, it was outside the scope of this lecture, so I didn't touch it because it is a pathological. Stage groups, again, it's similar to the chart we've seen in the previous page. So again, with this staging, it helps the surgeon or the oncologist to know where this patient needs to go to next in terms of management. So for follow-up of patients who've had patients with breast cancer, it is recommended that annual mammography is done for screening in patients who've had previous breast cancer with either breast conserving surgery or patients who've had unilateral mastectomy. You need to surveillance and survey the contralateral breast or both breasts in cases where the surgery was partial breast conserving surgery. So annual mammographic follow-up is recommended so that you are able to detect abnormalities before they become palpable. or clinically evident masses or pathology. MRI is a useful modality in assessing local recurrence, and especially where you've had surgery done. After 18 months, usually, if you see an enhancing area in a place where there was a previous surgery done, that is a place where you need to now look at more keenly. You need to biopsy that area and assess for any recurrence. So it's important to note that recurrence may occur locally or in contralateral breast or distant sites, which is why usually, even for patients on follow-up, we routinely will have, other than the mammogram, there will be the routine CT of the chest, the abdomen, or an MRI of the abdomen and pelvis done to just ensure that there's stability of this breast cancer. And also of importance is a comparison with previous images. A lot of our patients who are on follow-up will come, and we at times have patients who come and tell you they've lost images, they had the previous mammo 2 years ago, they don't have the images. So, and sometimes they've been done at different facilities. It's important to tell our patients that they should have all their hospital documents. So anytime they come for any other imaging or any other procedures, it's important for them to have those records, because then it tells us where we started from and whether we have stable disease or there be interval changes. Yeah, so thank you for listening. That is the end of my presentation. These are my references.
Hello, thank you very much, Dr. Mose, for that elaborate presentation. We've indeed learned a lot. You've done a recap of screening and diagnosis of breast cancer and taken us through the imaging modalities required in staging and even follow-up. We really appreciate it. Thank you. We will now go to Nelson. Am I audible?
You are.
Am I audible?
Yes, you're audible.
Okay, thank you. I think we will now go to the question and answer section. I must appreciate that there are so many questions which have come. The attendees have posted on the Q&A section. We've been able to answer a few of them, but there are some which are still existing, and some of them are even clinical in nature. Allow me to appreciate breast surgeon, Professor Wasike, who has also logged in and has actually posted so many important questions on the forum. And I would ask that some of the questions may be clinical. I'm not sure whether he could be in a position to answer them, but I will start with the radiological questions, which are still pending, and I'll ask Dr. Mose to answer them. Maybe one of them is Dr. Linda. Abigail has asked, how does breastfeeding affect screening results using mammography/MRI? Can FNA or core biopsy be done in a breastfeeding woman? Dr. Mose?
Thank you for the question. So we know in breastfeeding and in lactation, we tend to have a lot of the physiological changes where you have the proliferation of the fibroglandular elements, the ductal tissues. What is recommended is that the patient can actually express prior to the procedure so that the ducts are not engorged at the time of the study. You can express, and after that, have the procedure immediately after. And usually, this will not interfere with the results for screening mammography. And especially the reporting radiologists are usually familiar with the patterns of the patterns you see in the different types of breasts, so in lactation, in pregnancy, and generally what we say is express before you go for the screening. This will help again reduce that the appearance of, the ducts, so that they're not engorged at the time of the study. So also in terms of enhancement, remember the types of enhancement we talked about when you give gadolinium. You have the foci of enhancement, you have the mass, and then you have the non-mass-like enhancement. These are the other features we look for. And people who are well conversant with reporting mammograms will be very comfortable. So it does not affect screening. FNA or co-biopsy can also be done in breastfeeding women, but you have to be careful as to what you're doing the biopsy on. We don't want to biopsy ducts where you have inspissated secretions. So it's important to also have the imaging evaluation done. And by the time this patient is actually being told to have a biopsy, then you know you're dealing with a mass or likely dealing with something that is suspicious for malignancy. So things like inspissated secretions, where you tend to see secretions within the ducts or milk that is contained within ducts and maybe has thickened over time, these ones we don't biopsy. But if you have a mass within the breast or even an intraductal mass that you see, definitely this will not stop you from doing biopsy in this patient.
Okay, thank you, Daktari. Rifat has asked, so if the pectoralis muscles is involved alone, which stage is that? Is it T4? If the pectoralis muscle is involved, which stage is that? Is it T4 or which stage is that? Dr. Mose? Hello? Hello, Dr. Mose. Can you hear me? Okay, as Dr. is preparing to answer that, if I could ask Professor Wasike, if you are still logged in, could you answer one or two clinical questions posed here? Kindly, if it's not too much to ask, if you could raise your hand so that our coordinator can enable you to talk. Nelson? Nelson, kindly look for Professor Wasike on the group so that he can answer question.
All right.
Professor Wasike, I think he's logged in as Ronald Prof. Wasike. Kindly enable him. Have you found him?
Yes. Prof, you can go ahead and unmute. Thank you.
I have unmuted.
Okay. Professor Wasike, good afternoon.
Good afternoon. You can hear me?
Yes, we do, Prof. We really appreciate you having logged in. And there are a few questions here which are clinically oriented, and I believe you're in a better position to help us answer them. One of them is from an anonymous attendee. With such an elaborate investigative approach, one still wonders the justification of either incomplete excision or recurrence tumors in the immediacy. What is your response? The justification for incomplete excision or recurrent tumors in the immediate time.
The main challenge, Doc, is the lack of teamwork. Because if you are doing breast conservation surgery, for example, where you are talking about leaving positive margins, for you to be able not to leave the positive margins, you need to discuss with the pathologist so that they can do frozen section for you. And then before you actually finish with the patient to close the wound, they will have given you the margins. How far is it? Is it 1 millimeter? Is it 2 centimeters? If it is less than a millimeter on touch prep, then you have to exercise to shave the margins before you close. Preferably, you take the shaved margins back to the pathologist to clear you before you close the patient. And since you are always, when you're doing breast conservation, you're also looking at the lymph nodes. I prefer that if you're doing sentinel nodes, you take the sentinel nodes to the pathologist, and then now you continue with the lumpectomy, and then you take the masses there and get the margins cleared by the pathologist. Routinely, it's not easy because we lack the coordination, and also in many facilities, we don't have a table for the pathologist within the theater. But in some centers, that's for you to do breast conservation, or so that you're able to know that you've cleared the margins. You must coordinate very well with the pathologist, with the histopathologist to tell you the margins during the operation. Not after you have taken the specimen, then it comes back as positive, and then you want to go back and redo the surgery. It has to be a coordinated intra-op assessment between the surgeon and the pathologist, the histopathologist.
Thank you. Thank you so much, Prof. Another question for you.
Yes.
There's a question here from Kefa Manduku. What would be the reason behind a patient being examined initially and nothing proper is diagnosed, only to be realized later when the cancer has gone to about T3?
The reason is lack of imaging. You know, like as you always emphasized, it has to be triple assessment. Our fingers, okay, clinical breast examination has only a good output of 25%. We did this with Dr. Mtebi, that was her dissertation, as compared to ultrasound and mammogram and the other imaging modalities. So when doctors decide that I've already made up my mind that there's nothing you're feeling and I can't feel it without doing imaging, then that's how that happens. That's number one. Number two is that most of the patients go to their gynecologist when they have a breast problem. But you know that there's no chapter on breast in gynecology except breastfeeding. And yet, of course, you find even gynecologists doing lumpectomies, and then most of the time they come back as cancerous because they thought it was just fibroadenomas. So it's keeping that very crucial point of imaging the patient. And as Dr. Moses has already said, the mammograms can pick up lesions 2 years before the doctor and the patient can feel it. So that's why screening becomes very, very important for patients who are over 40 mammogram. Those who are below, we use MRI or ultrasound before we conclude that there's nothing wrong.
Okay, thank you, Prof. There's a question here you've asked on the chat, and I would wish to pose it back to you so you can answer it for us and even elaborate for us. There's a question you posed here concerning staging of breast cancer, apart from TNM staging. How does the molecular subtypes affect the actual stage? And as Prof is answering that, Daniel, please look for Dr. Rose Ndumia. She's logged in as Rose Ndumia. She can answer for us the question of T4, the pectoralis muscle being involved on imaging. Prof, please, could you answer that for us?
So for
TNM staging and the molecular subtypes.
For a long time, for staging of tumors or cancer, we utilize the size of the tumor, not on local node involvement, and then distant mets. That is before we discovered that biology is the king. It's not the anatomy that is the king. So once we discovered the issue of immunohistochemistry and then dividing up into luminal A, luminal B, HER2 enriched tumors and triple negative, we realized that even from a very small size, triple negative and HER2 diseases, HER2 enriched diseases are going to be very, very aggressive, and their treatment, so that even if you have, like, say, a T1 or a T2 triple negative disease, will cause the patient more problems as compared to even a T3 ER/PR positive disease. So that when you're looking at the TNM stage, you also have to combine and think about what subtype of breast cancer are we dealing with? Are we dealing with a natural, very aggressive disease, or are we dealing with something that is friendly to the patient? And therefore, after the 17th series of staging, and they started including the subtypes, the actual stages actually really changed from the normal TNM. I don't think I've explained this clearly, but I think it needs a lot of understanding that the tumors that they are triple negative or they are too enriched, regardless of their size and not involvement, they are going to behave as if they are stage 3 or 4, compared to the ones that are hormonal receptor positive. This is the point I was trying to bring up in terms of staging, what's current and the current thoughts.
Thank you so much, Prof. Thank you. And I'm so sorry again for ambushing you.
No, it's okay, anytime. That's why we are here for each other. And thank you very much for organizing this talk. I had a clinic, but I had to stop it for a while and just go through this.
Thank you, Prof. We appreciate. Daniel, could you trace Dr. Rose Ndumia on the call? Rose Ndumia, she's a specialist radiologist at Aga Khan Hospital, specialized in breast imaging.
Dr. Mamai, I'm here.
Yes, Doc. I've seen you've commented on one question. Someone had asked about involvement of the pectoralis muscle, whether it changes the T staging. Kindly go ahead.
Oh, thank you, Dr. Mamai, and also thank you, Dr. Mose, for that enlightening talk. So the pectoralis muscle just lies behind the breast tissue, and often there'll be questions of whether, when it's involved, whether that changes the T stage. And the answer is no, because the pectoralis muscle does not compose of the chest wall. When you read about TNM staging in breast cancer, the T staging changes to T4 when there's skin or chest wall involvement. And chest wall represents the ribs and the intercostal muscles. Therefore, involvement of the pectoralis muscles does not change the T staging to T4. This is because surgically, the breast surgeons, while they're doing the mastectomy, they're able to even shave off part of the pectoral muscle that may be involved by the tumor. Whereas when you think of it, if the chest was involved, you cannot go and remove a rib, you cannot go remove the intercostal muscles because you'll end up with a pneumothorax. So pectoralis muscle involvement does not change the T staging. It's skin and chest wall.
Okay.
Hope that clarifies it.
Yes, Dr. Ari, thank you so much. Any comment you'd want to give on breast cancer imaging and staging?
I think the role of PET scan is one of the things that I've seen debated quite a lot, even during multidisciplinary meetings. And I'd just like to emphasize that FDG PET scans are not used for the initial staging of breast cancer. You still go to your routine CT scan of the chest, abdomen, and pelvis. However, you may find that you have indeterminate lesions that you can't, on those imaging, you can't really tell, is it metastatic or not? And that will change the prognosis and the management of that patient. So let's say you see this lung nodule and you're not sure whether it's metastatic or it's just a granuloma from previous disease and you don't have prior images to compare, then a PET scan would be useful. Maybe you see a bone lesion and you're not quite sure whether this is a bone island or sclerotic metastasis to the bones, then a PET scan would be important because it changes the whole ball game, whether this patient is going to be a stage 4 or not. So you bring it in the initial staging for problem solving of lesions that you're not able to determine on your routine imaging. Where else does it become important? So once treatment has been done and these patients are under surveillance, they're seeing the oncologist regularly, their certain blood tests are being done. So one of the tests that they do is something called CA15-3. It's a tumor marker for breast cancer. And when this is being monitored and you start seeing rising CA15-3 titers, and again, your routine imaging is not showing or depicting an obvious area of disease, then a PET scan becomes important to determine where these CA15-3 titers that are increasing are originating from. It might be a very subtle lesion that you can't pick up on your routine imaging. Another area that it becomes helpful is when you're thinking of bone metastasis and you can't really identify a lesion on your routine imaging again, your normal CT scan, chest and abdomen. And you have two alternatives when you're thinking about bone lesions. You can either do a bone scan or you can kill two birds with one stone and do your FDG PET scan. So these are patients, when you do your alkaline phosphatase, you'll be seeing that they're quite high. And so you could opt to either do a bone scan or a PET scan to determine if there's bone involvement, if your routine imaging is not depicting with confidence. That's it from me. Over to you.
Thank you so much, Dr. Rose Ndumia, for your input. Very much appreciated. And the role of PET-CT has been clearly outlined for all of us. I don't know whether Professor Wasike has dropped off. I forgot one question from an attendee here who is asking, if a mother has benign breast tumor, can the mother continue breastfeeding the infant? Prof, are you still there?
Yeah, I'm around.
Okay, could you answer the concerned person here?
Benign disease like fibroadenomas, cysts, and all that, yeah, they have to continue breastfeeding. They will not interfere with breastfeeding.
Okay.
Yeah.
Thank you so much, Prof. Thank you. Dr. Mose, you are parting short. I think this has been a very engaging discussion, and we most definitely appreciate the team from being very lively, and the questions are still there, and the answers are coming from all specialists in the group. We appreciate. Yes, Dr. Mose?
Yeah, I need to thank you for organizing this session. We can't emphasize the importance of having screening in breast cancer diagnosis because we would like to have patients who, we'd like to have a healthy population, or in the event that we have cancer, we are able to catch this disease early before we have advanced disease or metastatic disease. So that we improve our survival rates. And as we said, in our population, we're again seeing a lot of patients, younger patients who are getting cancer, breast cancer at very early ages. And it is something that probably we should research about in the different, even from the clinicians, and even as we image. These are things we could actually try to research and also have our own data and see what is it that is making our population of patients get malignancies at a much earlier age. It is something we keep raising as a concern, even as we report in the department. But as it is, we have no answers as to what has changed the demographics. So it would form a good topic for research, so that we're able to see how to mitigate some of the factors that may be predisposing us to this cancers. I'd also like to thank the attendees who've attended the session today, and those who contributed to the sessions. Professor Wasike, thank you, Dr. Rose Dumia, for the questions and also for the answers to various questions raised. And we're hoping that we'll continue engaging and having more multidisciplinary team meetings, because all oncology patients ideally should actually have MDT discussions, so that when treatment is done, it is tailored towards that patient. And we hope to have improved patient outcomes. Thank you all for attending. That is my parting shot.
Thank you so much. Thank you, Dr. Mose. And there was a comment from one of the attendees about when we are going to deal with benign breast lesions, because apparently there are patients who wake up surgeons at 3 in the morning. So yes, we've had that comment, and we will arrange for discussing benign breast lesion. With us, we have Dr. Angeline Ayuak on the call. We consider her as the mother of radiology in the University of Nairobi. Dr. Ayuak, do you have any comment before we close? Please unmute.
Yes, I've unmuted. Thank you very much, Tim. Thank you for the teamwork between the UON and the Aga Khan University. Maybe next time we'll make sure even in Jomo, even Kenyatta University is also involved in this program. So thank you very much for the presentations. Thank you, Team Aga Khan. Thank you, Kenyatta, and thank you all of you for organizing this and bringing out all that has been done today regarding breast cancer, which is the #1 killer of our women in our country. Personally, I've lost 3 former classmates to this breast cancer, so it's usually passionate. And the real mother of radiology is actually Dr. Wambuku. We used to call her Mother Superior, so I'm just hanging in there. And thank you very much for allowing me to talk.
Thank you so much. Thank you, Dr. Ayuak. So we want to appreciate all the attendees. Thank you.
I'm happy to see all of you actively involved in these things. As some of us plan to retire, we know there are people who are behind us who are taking it forward.
Thank you, much appreciated. So thank you all for attending. We conclude our series for this month of October for breast cancer awareness. I believe there's another team that will be presenting this week on Thursday through the coordination of the National Cancer Institute, but we will be informed about it. Nelson, there have been many concerns about the CPD points on the platform. Maybe you can be keen on sending people their CPD points in time. So thank you all and much appreciated. Bye.
Okay, thank you, Dr. Mamai and team, for the insightful presentation and also a very fruitful conversation. We will be back tomorrow with a session by KRA on tax amnesty. So kindly be keen to join us and see what they have to offer us in regards to our tax amnesty that we are allowed through the KRA. So thank you and do have a good day. Goodbye.
Bye. Bye.
Thank you.